Hello, welcome, good afternoon, good morning, everyone. Thank you for joining this ISB Partnerships for Life webinar. As most of you know, Partnerships for Life is the ISB program to support collaboration in the development, in the revision, in the implementation, and in the evaluation of national suicide prevention strategies. And part of the work we are doing is to have regular webinars. And today our webinar is hosted by the European region. I'm Thomas Niederkrotenthaler from the Medical University of Vienna, and I'm the coordinator in the European region. And due to the size and the complexity and diversity of the European region, we have a regional leadership team. And with us, also one of the speakers today is Professor Vita Poštuvan from Slovenia. She is the sub-regional lead for Southern Europe. The other coordinators are Professor Fabrice Jolin from France, who is coordinating the Western and the Northern European region. And last but not least, Dr. Zrinka Laido from Estonia, who is coordinating the Eastern European region. On behalf of the ISB, thank you for joining this webinar. And please note that this webinar is recorded. And also, we would like to point you to resources and crisis support, which are available on the ISB website /suicidal thoughts. So it's www.isp.info/suicidal thoughts. You also get this information in the chat window. Our webinar today is dedicated to the topic of postvention. Now, postvention is or should be part of all national suicide prevention programs and strategies. Still, it's often an under-recognized and underrepresented area. We have three wonderful speakers from different European regions, and each of the speakers will have 20 minutes to present on their specific work they are doing in the area of postvention. And I really encourage you all to put in your questions into the Q&A section, and there will be time after each of the presentations for some questions. Our first speaker is Dr. Regina Seibl from Austria. Regina is a mental health professional working for Mente Tirol, a community mental health agency in Austria, and she's a postvention practitioner for family loss survivors and mental health professionals after patient suicide. She's a trainer for the suicide prevention and postvention and mental health first aid, and she's a member of Suicide Prevention Austria, the Austrian National Suicide Prevention Strategy. She's also head of SUPRA's working group on postvention for mental health professionals after patient suicide. And her talk today is postvention for mental health professionals after patient suicide. Regina, the floor is yours.
Thank you, Thomas. Hello, everybody. I will share my slides now. I hope it's working. Okay. Yeah, okay. So I will talk a little bit about postvention for mental health professionals after patient suicide. Okay, let's look at the statistics for different professions in the mental health field. As you see, we have really staggeringly high numbers of psychiatrists and other professions who will experience at least one patient suicide during their career. So it is safe to say, I believe, that losing a patient to suicide is an occupational risk in our field. Unfortunately, what we see is that many of us are not prepared. And there is a lack of standard procedures after patient suicide in facilities, and there are hardly any postvention trainings for mental health professionals. What can be possible reactions to patient suicide, though? There are different factors that will shape our individual experience, and those can be in the field of the patient, like diagnosis, duration of treatment, circumstances of death. Some factors come with the mental health professional themselves, like work experience, personal background, perceived closeness to patient or gender or the like. And last but not least, it has to do with our setting. It depends on if we work at a clinic or at a community mental health center, or maybe in individual practice. Quality of team atmosphere and support received are other factors. So what many of us experience after patient suicide is an initial shock and feeling of numbness. And pretty soon intense ruminations will set in around questions: what happened, what were the contributing factors to the suicide? And one main question will be, for most of us, did I miss anything? Many experience physical stress reactions like loss of sleep or loss of appetite. Some even experience trauma reactions like feeling powerless or overwhelmed or having intrusive thoughts of the suicide. Some feel angry at the patient, at others, at other colleagues or facilities that were treating the patient, or some are angry at themselves, especially if they blame themselves. And many experience sadness and at the same time question themselves if it's okay to feel sad, if they are entitled to feel sad and bereaved maybe. And this can lead to disenfranchised grief, unfortunately. One very central aspect of our reactions to patient suicide are feelings of guilt and responsibility for the suicide. They really are very common, and in my opinion, they come almost like a reflex. This can lead to blaming ourselves for the suicide or maybe others. The main question is, who is responsible for it? Who made a mistake? Some can experience fear of legal consequences, for example, or a loss of reputation maybe, or the worst thing would be fear of losing more patients to suicide. Shame can be a reaction for some, especially if they feel guilty or if they experience vulnerability and sadness because they don't want their colleagues and superiors to see them that way. And especially if we do not receive support, if we do not get an opportunity to talk with our colleagues about how we feel, this can lead to isolation. And in the long run, a lack of support can lead to detrimental effects on our clinical practice, like questioning our professional identity or role, maybe questioning the effectiveness of our services as a whole. Some will experience a loss of clinical confidence or feelings of incompetence. Some will have difficulties to trust their patients, especially if the deceased patient did not disclose their suicidal ideation. Some will experience self-doubt and intense insecurity, especially when working with suicidal patients. And this can lead to an avoidance to treat suicidal patients altogether. Some, especially those who did not receive support from their colleagues, have a loss of trust in their colleagues, in their superiors. Maybe there was even some blaming or scapegoating going on. And all these things can lead to considerations of leaving the professional field. Some even do. So those effects are really, should be avoided in my opinion, and can be avoided. As we see, it can have a significant and long-lasting emotional and professional impact on mental health professionals to lose patients to suicide. If we look at their needs and what can be helpful, so the basic thing or the bottom line should be that we have a framework that is providing a sense of safety and guidance and is clear and coordinated. And with this framework comes an acknowledgement of grief reactions and needs of the team. And one of those needs is to have an atmosphere of encouragement and support. Some of us may be really severely affected immediately, and they should be relieved from pending tasks. They should know that colleagues can take over or that they have permission to go on sick leave, for example. And the central theme is really to get opportunities to reflect on and to process the suicide in immediately and in the long term, not just one time, several times, to talk to our colleagues and to get support. And a basic thing also is to get backing from superiors and colleagues and not to be blamed for the suicide. And in my experience, it's really important to have a chance to gather information about the suicide in order to understand what happened. That is like putting the pieces together and find a narrative for the suicide, so we can find out about our own possible role in what contributed to it, and to possibly learn from it. Yeah, what can be possible learnings? Some will come away with more realistic expectations around their own ability to help patients, and hence a reduction of ideas of omnipotence. We can learn from possible mistakes, if there were any, in order to improve our services. Some come away with an increased sensitivity to warning signs and risk factors for suicidality, or even with improved skills in working with suicidal patients with less anxiety in the background. Some will experience increased trust if they received support and they know they can rely on their colleagues and superiors. And that might eventually lead to a heightened resilience in an individual and in a team. And some will even experience a greater acceptance of suicide as a tragic but possible outcome for some patients. Of course, that is a sad reality, that we will lose some patients to suicide despite our best efforts. Postvention can and does help achieve these learnings. Postvention can have immediate goals, such as to reduce stress, anxiety, and the emotional burden mental health professionals experience. It can calm intense dynamics after patient suicide. It can and should normalize grief reactions and thus reduce shame. And it should provide a sense of safety and guidance for everybody, and a learning opportunity as well. And its long-term goals are to help stabilize affected clinicians, to restore their work performance, and to keep them in the field. And maybe improve the ability to work with suicidal patients and improve our resilience. So what does postvention look like? What is postvention in action? There should be tailored guidelines present and available in every facility working with psychiatric patients that can help us to know what to do and to guide us through the process one step after the other. There should be an awareness about possible reactions and the needs of the team in managers and superiors who are in charge for the whole process. And therefore, it would be really good if they receive postvention training in advance. And there should be knowledge about the care for other patients who might as well be affected by the suicide that happened. And there should be knowledge about how to get into contact with the bereaved family. All these things and all these aspects of postvention need careful planning, implementation, and evaluation as well. what else can provide postvention? There are some models out there. And one of them would be a model of mentorship that usually means a peer with lived experience has a designated role in an organization to aid with the formal processes, to provide support to the team, and to get in touch with the bereaved family. And another model would be to provide peer support in group or individual settings done by colleagues and seniors. And there's, in some cases, there's online support group meetings that can be attended. So my recommendations would be to really establish guidelines as a standard in the mental health field, and to do prevention and postvention trainings for mental health professionals working with psychiatric patients. And that is my vision, really, to have more awareness of this topic in the suicide prevention field. Thank you for your attention. I was trying to speed up my presentation now. And at the end of my presentation, I would like to draw your attention to some initiatives or to special material. The first one is Suicide Postvention Europe, SPE. It's a network that has been formed in 2025. It's a young network to strengthen postvention as a vital part of suicide prevention. Via this QR code, you can join us and check out what we're aiming at. And the second one is a paper issued by the Royal College of Psychiatrists that gives a prevention and postvention framework for the mental health field. And the third resource is the website of the Coalition of Clinician Survivors that is US-based. And it contains a lot of relevant information around this topic. So that's it from me. So if you have any questions.
Thank you so much, Regina, for sharing your insights with us. Now I'm looking at the chat and I don't see any immediate questions in the chat window. Now there's a weird thing. I don't see a specific Q&A window here. So Kezia, if you can see that window and see some questions there, please let us know. But as a start, I have a question for you, Regina. I mean,
Okay.
the numbers are really stunning. So many professionals who are affected and impacted by patient suicide. Are you aware of any efforts to include this also in the curricula of professionals already? Because it seems to be such a relevant topic, or any other resources that you can point our other participants to where they can find information how to cope.
Mm. So I absolutely agree, Thomas, that this should be included in the curricula, and we should really, before we start working with psychiatric patients, we should have heard about what can happen to us and what to expect, and the types of support that may be available, hopefully, to us. So I've been talking to a professor here in Innsbruck, and she would like to include that subject for one. But other than that, I'm not really aware that this is done regularly. But I'm hopeful. So maybe we can start something.
Thank you. There's a question if it's possible to share the slides with the resources, and I think yes, we will
Absolutely.
share. So Kezia will share the PDF of the slides of today's presentation.
We'll share the recording, not the slides.
Okay,
Thomas.
okay.
Yeah.
But you, okay. Okay, wonderful. So I don't see any further questions. So thank you again, Regina, for sharing this insight. And we continue with Postvention. Our next speaker is Professor Vita Poštuvan. Everyone knows Vita. She's also one of the coordinators of the Partnerships for Life program here in Europe, for Southern Europe specifically. And Vita is a psychologist and works as a researcher and deputy head of the Slovene Center for Suicide Research. at the University of Primorska. She leads the work in the fields of clinical research, public mental health, prevention and interventions in suicidology, bereavement and crisis management. She's a member of the National Unit for Psychological Support in Civil Protection and works as a CBT counselor as well. And Vita is going to speak about school-based suicide postvention needs, practices and challenges. Thanks for being here, Vita.
Thank you, Thomas, for inviting me and for this nice introduction. I'm thinking that, you know, people always know those that are a little bit misbehaving, so I'm not sure whether that's a good sign or not. People know who I am. But a little joke and a warm welcome from my side. So I will be talking about the school-based suicide postvention, as mentioned. And hopefully this will be working. Let us see. Can you see the slides moving? Yes? Oh, right. Yes. Okay. Okay, that's a relief. So I come from Slovenia, as it was said, a country in the middle of Europe with relatively high suicide rates still. So the rates are higher than the average of EU or the average of the world, despite the recent decline that we had that started around 20 years ago. But now maybe we don't see such a decline anymore. We see a little bit of a plateau. But despite these very high numbers that we had traditionally in Slovenia, what we can see in the field of postvention, very interesting, is that there doesn't exist any specialist association for suicide survivors in Slovenia. In most of the countries around the world, you find this kind of association organized either in the NGO sector or some other ways. But in Slovenia, it's very strange that this kind of association is not existing. And people who are bereaved can find support in non-specialized support systems. There's a few, for example, psychologists, psychiatrists, therapists that work with this specific topic. But other than that, usually people find it in the healthcare, for example. There is a current action plan to create paid ways to professional support in a better way, because we have this interdisciplinary working group on suicide. But this is still in the process. So this is just where I come from. And Thomas already mentioned my competences, but I want to mention that our center, Slovene Center for Suicide Research, was established in 2011. So we do a lot of research projects. We do a lot of promotion of mental health and awareness events. Of course, also a lot of research, but we also do a lot of psychological interventions and preventive actions. So this is also how the work in school-based suicide postvention has started. Many of you might know the Seibl project, which was a EU-based preventive research project that tried to address suicidal behavior and also some other problems of youth. That was coordinated by Karolinska Institute. And we started at that point to actually engage with the school systems in the preventive manner. So our aim was at that point to do the research and to study how can we prevent suicide. And we were quite lucky because we were able to after the project ended, we have changed it a little bit, or we have used similar methodology, but we have managed to secure the funding and to provide preventive interventions for the next period since then, actually. And we have developed several suicide preventive programs in Slovenia. But why I'm saying that? Because while we were running prevention programs at the schools, so for example, interactive workshops for the youth, case management support in suicide attempts of young people, we were doing psychoeducational training with the teachers or parents. Of course, the needs were obvious, and the schools turned to us also in cases when suicides happened. So, and it was a natural way then that we felt we need to respond, we need to be proactive, we need to have a plan how to react to these cases. And I showed at the first slide that we have around 370 to 400 suicides per year in Slovenia. It's a 2 million nation. And around 10 to 15 cases of these are youth suicide. So they affect the schools very much. So we can see that the numbers maybe are low because we are a country with small population. But anyway, you can imagine how these effects have a big impact on the surroundings. So when these needs were very obvious to us, we offered, first of all, maybe not so structured interventions, but then we started to address this issue more systematically. We made a needs assessment and we asked the schools that had recent cases of youth suicides to tell us what they actually needed on the day when the suicide happened, a few days after, and we structured that in the different time periods. And also, of course, we looked at the protocols from abroad and from the other crisis situations, because some of the reactions that we see in suicide, postvention or bereavement are specific to suicide, of course, but some actually can be related also to other crisis situations. So we learn from those also. So what we found is that, of course, the needs are different on the different levels and to the audience that we want to address. And what we found is also, in a way, we included in the guidelines that we created together with different colleagues from different organizations, but mainly the Institute of Public Health was coordinating that process. So there were guidelines for the schools, how to do, how to act when there is a suicide of a pupil or a student. And we addressed different target audiences there, so to say, but we still see that in many cases it is much appreciated that some organization from outside comes to the schools and provides some kind of interventions. These guidelines are mainly targeting, so to say, the school principals and school counseling services, because they are the ones usually involved. We call it as a crisis team that respond and organize the activities. But of course, there is a need for the to address other groups also. And I want to maybe be very concrete today and tell you what we actually do when we go to the schools. So this is our main activity plan, so to say. We usually, and the way we actually address the needs differs very much upon what the situation is. So sometimes we do only the support to the crisis team, so to the headmaster or psychologist. And this is in cases, for example, when this crisis team has a lot of competences themselves. Maybe they are trained psychologists, maybe they are trained psychotherapists even, and they know how to handle this kind of situations. And they say, well, just give us the basic orientation, and then they're actually fine with doing a lot of debriefing and a lot of support to the youth, to the students, to the teachers by themselves. Sometimes they just need this framework, what is good to do and what is not. But sometimes they want us to actually come in and to do, for example, what we usually do is a debriefing session with a class where the friends of the deceased student was. And we also do debriefing or even psychoeducational sessions with the teachers and with the parents of the peers, of the classmates. So this is a different intervention, and all of those three that I have mentioned now, we do usually in the group setting. Sometimes these groups are even very big because, for example, when we have the meetings with the parents, sometimes there is a big interest in that because they are also scared, for example, how this will impact their children. But we do more individual or pair or small groups when the needs are bigger. For example, we do a different kind of debriefing sessions with the best friends or most affected friends, and we do that in individual setting or in a small group, as I said. And it's very similar also to the teachers that are most affected, because it is very important that we manage to empower the teachers so they can manage their emotions, because they will be the ones going into the class day by day, seeing that this person, this pupil, the student is not there anymore, but they will have to manage also the emotions of the pupils. So sometimes they need a separate session, usually also before we go into the class, we talk with them. And to provide them really some good support. And we also offer supportive sessions with the bereaved parents. And we call all of these interventions as the first psychological aid intervention. So we actually provide this more or less support within the first week or so. And we try to then refer people who cannot deal with the situation to the further services that are available in Slovenia. So we don't support them, for example, for the whole year when we know maybe sometimes they would need this kind of support, but we try to then engage with the services that are available in the country. Sometimes this kind of schools also later on want to be involved in our preventive workshops and preventive actions, because of course now they know that this is a topic that can happen also to them. And of course we also know, due to all the exposure to the suicide that these kids at the school had, there could be repetition, and therefore we are also very cautious that this kind of effects don't happen, and we try to offer preventive measures also there. And sometimes we even actually are involved with the working organizations of the, for example, bereaved parents, because also those organizations, this is a little bit outside of the school setting, but you know, they sometimes call us up because they don't know how to support or help their colleagues when they will be returning to the work. So this is just in a little presentation of how many of these activities we are doing, and it's not so important about the numbers, but you can see that how clustered they are. So it means it usually refers to the time of the year when there are more suicides, and also unfortunately we see that sometimes there might be some Werther's effect happening when young people see one case and there is immediately a very similar case happening in Slovenia. After such a case, you can imagine there is a lot of intense communication. So this is something that we all have to be very much prepared of. I will not go into all of the details of how the communication looks like, but everyone who works in this field sees that you know, it's not only that you are contacted by the school, but also a lot of external services or external people. Journalists try to get the information from you, the public, and so on. And you have to go to the field work, to the post-vention activities very well prepared. You need to know what happened, when it happened. You have to organize the session very well. So you have to have these competences of actually organize things for the schools. Sometimes you have to tell them there need to be a classroom like this and the groups of a size like this, because the schools will not have this information in their minds when organizing. And of course, part of the preparation is also your emotional and organizational preparation of the team that will go to the field. This is what we actually do in the majority of the cases when we go to the classes. So we try to open the conversation, we try to express condolences very directly, and to also establish very safe environment, and then talk about the event, what thoughts it caused, what were the reactions, interpretations of why the suicide happened, how it affected them emotionally, the pupils or the students, what kind of effect it had, and then we offer a lot of psychoeducational input in terms of how the grief looks like, what the bereavement process will be like, and how to help yourself and the others. And of course, how to engage in the rituals to create kind of events that will give maybe some meaning or to the whole event. We also try to reflect the process, and of course refer those that would need additional help, as I said before. And sometimes we do very similar to the adults, so to parents or teachers, or sometimes we do more psychoeducational settings where we try to actually address two main questions. why this happened. So explain the complexity of risk and protective factors and misconceptions about suicide, and of course the guilt. And the other question, how to prevent suicide for my child. So how to recognize signs and how to react towards it. What we try to avoid, of course, and this is some of the guidelines that you might know, of course, is to offer the first support in relatively short time, so not longer than 10 days after the event has happened, because then you cannot do the same kind of interventions. Maybe it's still meaningful, but it needs to be addressed in a different way. A lot of times the pupils say that they had hard times accepting that some people, some adults pretended like nothing happened when actually they have lost a student. And probably I say that it's not because the adults, the teachers didn't want to address it, but probably it's because they couldn't really address it, because probably they didn't have the capacities, the knowledge, the emotional regulation skills, how to actually do it without maybe going into the tears too much or something like that. So it is very important that the students or the pupils that are probably from all of these groups that we see in the schools, the most vulnerable group, that they actually, their loss is addressed, but also that's what they a lot of times say, that things also move on while the time moves on. So it's not like that we are stuck with this event and this is the only thing that we are focusing on, because their lives also move on. You know, they will be growing up, and their process shouldn't stop because of this event, actually. So being very patronizing towards them is also something that usually they don't appreciate. Now, what we see as a challenge, and then I will stop. We have, I think, three major challenges for us as a scientific community in a way, or as a professional community. What we saw in the past years is, as I said, also in Slovenia, that there was a decline of suicides. Now there are some trends that say that there is a rising rates of suicide among youth, and especially the onset of the suicidal behavior is going down. So the kids are younger engaging in suicidal behavior. That means that we might actually have, and this is what we are seeing in Slovenia also, cases where we actually do the postvention activities with the very young, for example, young teens being aged 11 or 12, which is very different to the interventions that we offer more traditionally, so to say. For example, a little bit older group, 17, 18-year-olds, because we know that bereavement processes depend on the children's developmental phases and their ability, cognitive ability to understand the death. Of course, being 11, 12, they already understand in the majority of cases the concept of death, but still the interventions and their emotional reactions towards it, their defense mechanisms are very much different at the age of 11 or 17. So this is a challenge, and we have a few cases that I see the difference, but it's still, you know, again, it's a little bit of a challenge because Slovenia is a small country. We go and offer the postvention, but still it's not like you do 100 cases per year, thanks God. But I want to say that developing your own skills or the team skills, it's very difficult in a way. And this is another challenge. Actually, I already put it here: how to build the competences in the team that actually delivers this, and also how to research the effectiveness. It's very difficult to do proper research in this area, so to say, proper in terms of randomized controlled trials that could be offered in one or the other place and compared then. But we have, for example, some studies that show some competencies building when we were delivering some educational, for example, workshops. But we also have to know that what has been proven to support people bereaved by suicide is the networking, and this is something that we are trying to establish in the future. So peer support, school peer support to one school that had the experience offering support to another seems to be very, very important. And of course, the last challenge is to prevent compassion fatigue by the people who offer this kind of support, similar to what actually Regina was telling before. We need to have preventive measures in mind. We need to have enough intervention and supervision, and also manage cases very well. So distribute the cases among team members, and then to also offer off time so that people can recharge in a way. It is easier, I think, if you see this kind of work as your own, how do I say, as something that makes your life meaningful also. So ikigai as a Japanese concept might actually help, because then you kind of also feel that this is a part of your own purpose. So again, the invitation to invite you to the Suicide Postvention Europe network that Regina shared before, and also, of course, to the Suicide Bereavement and Postvention SIG that we have at the ASP. Thank you.
Thank you so much, Vita, for sharing this very practical insight, which is so important to have. So I'm looking at the chat window again. I don't see an immediate question. There might be one. Most of the suicide postvention programs are in Europe. Did you guys have a plan to extend those programs beyond Europe to other regions like Africa, Nigeria, where suicide cases are on the increase? Governments are almost doing nothing to help in these cases. Vita, can you comment on this?
Well, I can comment, but I'm not sure I have any real plan, so to say, but I can definitely say that how you deliver postvention and also prevention, but in particular postvention, it needs to be tailored to the local cultural environment. I think that's very important, because there are many death rituals and rituals around bereavement that are very specific to specific cultural aspects, and I think that needs to be taken into account. But I also can share that it's sometimes well, we've never had the chance to actually talk with any other country to expand this knowledge elsewhere. But maybe what comes to my mind is, of course, Partnership for Life that Thomas mentioned before, where we always talk about mentoring processes, or sharing the experiences. I prefer this term, sharing experiences, because I don't think we come from a country where I say we have a few cases per year. So, this is our limitation, so to say, which is good. We don't want to have more cases. But again, it's a very different environment coming into, for example, a big country where the system needs to be different if you want to cover the whole country. We are a small center, for example, and we can cover the whole area of Slovenia because it's such a tiny country.
Absolutely, and that's certainly a great point. Like it might also be a topic for the African discussion, the webinar from the African region. So something to consider also for the future. There's another question. Why do you call it debriefing? WHO said in 2012 that an emotional debriefing can actually be harmful. Shouldn't we use another name for these talks in schools after a suicide? It's not a standard debriefing. Any thoughts?
Yeah, thank you, Laura, for this very good question. I was actually, when I was preparing this talk, I was thinking, how do I call it? And I called it debriefing because, I don't know, for the translation from Slovenian to English, that is the best word that I could come up with, because otherwise I would always say postvention. And I want to actually say that we touch on the emotional part, so people can express those emotions, and I think this in a way is a debriefing. But I am aware of the concerns that were raised, and that a lot of times have been also proven by some evidence that some debriefing might be harmful, and this is especially if you expose people in a wrong setting, people that have not had the same exposure to the event, and then you actually give them more information, then they can be actually traumatized because of the debriefing process, not because of the event itself, and similar. So it needs to be a very when you decide you will do an intervention, it needs to have a lot of thought. why you're doing it, to whom you're doing, which is how the group composition is done. And this is the organizational preparation that I mentioned before. So maybe it's not the right word, and I agree on that, but so if you have any suggestion on which one to use, I don't mind changing it. I just wanted to express the content maybe more than the word itself.
Vita, I had another follow-up question. You have mentioned the tailoring to specific groups, and obviously you also mentioned that problem with suicide among very young children and adolescents. So you obviously need to do some adaptations here in your process. So can you just highlight a bit the main adaptations you have made in such a case?
Yes. So I think, for example, one case comes to my mind when I was delivering actually such postvention with very young kids. I think they were 11 or 12. And what definitely we needed to do is to have the questions and the way we addressed very simplified and very direct. So, because they don't understand very complex questions, and therefore also our questions needed to be very short and concrete. But also, what we did, we identified that there was one way of doing a session with the whole class, and there were, again, like I mentioned before, not everybody had a very deep connection with the girl that actually passed away. And then we did another session with the kids that were more affected. So it's also here, again, we were tailoring, what to do with the whole class because they were so much younger even, and what to do with more affected ones. So that comes immediately to my mind. So really simplify the processes but again, working in the field of suicide, it's very strange to say simplify because everything is so complex and you can't give them one question. So it's a lot of times also by going with how they understand and kind of trying to normalize their views and going with their understanding rather to giving them some scientific explanations, because I don't think 11-year-olds needs all the complexity at that point. It just confuses them a lot of times.
Mm-hmm. Thank you. There's another comment here. One of our participants posted a guideline, a resource in Postvention that can be translated to other languages. Will be available also in Japanese. No, that might be something that is of interest to many here. So Vita, obviously your guidelines are probably in Slovenian, but do you have any translation or the main summary points? We have some in German, obviously, but are you aware of any English guidelines on how checklists, how to cope with pupil suicide, for example?
Yes. There, if you Google suicide postvention in schools, there will be quite a number of UK and US based, mainly English. If you talk about English language guidelines that are available and that offer probably very similar interventions. So I think those that I know, that they also served us in a way as a basis when we were developing our own program.
Great. Wonderful. So I don't see any further questions. So thank you again, Vita, for sharing your insights. And we are going to the third speaker today. It's Associate Professor Edouard Leaune. Edouard is Professor of Adult Psychiatry at the University of Claude Bernard Lyon and the Hospice Civil de Lyon in France. He's head of the Department of the Suicide Prevention Center in Lyon and conducts research on suicide bereavement and suicide prevention at Research on Healthcare Performance Lab. He worked as an affiliate academic in the UCL Division of Psychiatry in 2023 and 2024, and his clinical and research interests are suicide prevention among people bereaved by suicide and the implementation and evaluation of postvention programs in the community. And he will speak today about a specific platform they developed for postvention. It's the platform Espoir. Edouard.
Thank you so much,
Edouard.
Thomas, for the invitation and for the introduction. That should be okay now. I'm really happy to have the opportunity to present our platform Espoir and the way we co-developed our online resources for people bereaved by suicide. So we all know the burden of suicide bereavement worldwide, both in terms of number of people bereaved by suicide each year, but also in terms of mental and physical health. We know that suicide bereavement carries a lot of difficult symptoms, including, of course, guilt, but also depressive and anxiety symptoms, post-traumatic symptoms, and also has an impact in terms of physical pain or risk of suicide. But the other point of suicide bereavement is that it carries a lot of questions, sometimes called the why bereavement or the why grief, because so many questions come to the mind of people bereaved by suicide. These are some example of questions that we receive on the platform about anniversaries, about managing the emotions of suicide bereavement, especially guilt. How to talk about suicide with children, how to manage to going back to work. Is it possible to go back to normal life or not? Do you still hear me?
Yes.
Yes, okay, so I do continue, thank you. So our idea was in France that we knew that some platforms were existing worldwide, in the UK, for example, in Canada, in the US, Australia, or New Zealand, but in France, we didn't have any resources for people bereaved by suicide, despite we have high suicide rate, higher than in the rest of the European Union. And we wanted to develop our platform based on evidence, on postvention, but also on lived experiences of people bereaved by suicide. So we published the protocol of our study, and we used framework, which is called the E2CD for evidence-informed, experience-based co-design, which is a novel framework, including people with lived experiences in all the aspects of the research process, and which delivers evidence-based care, meeting the needs of users by integrating research evidence and lived experiences. So it offers a roadmap to address some of healthcare's most wicked problems and hopefully
Edouard,
improve outcomes for some of the most vulnerable people.
Edouard, the slides
Yes.
don't move. We can hear you, but the slides don't move. Just, yeah, that's now another slide. Did you see BMJ Open, evidence-informed experience-based co-design? Yeah.
It's not working with the slides?
It didn't, but now we see a new slide, which is the headline is BMJ Open, evidence-informed experience-based co-design. That's the slide we see, slide number 11.
So on the slide 11, I showed what is the E2CD, evidence-informed, evidence-based co-design. This slide is about the great team that we had working on the project from hospital centers, Le Vinatier, Hospice Civil de Lyon, CHU de Lille, also a research team and a startup, Interview de Santé, which helped us in developing the platform, and of course a lot of participants, people bereaved by suicide, people from charities, and many healthcare professionals. So we used a three-step study design. Maybe I will be brief on that, using the information system research framework. I will present you the 3 steps so you can easily understand what we did. As I mentioned, we wanted to rely on both evidence-based information and lived experiences. So what we did first was a systematic review and an online survey about the use and the expectation about online resources for people bereaved by suicide. So we did a systematic review that we published in Preventive Medicine, relying on 12 studies, showing that online resources were mostly used by middle-aged women and parents who lost their child by suicide and recently bereaved individuals. That online resource offers a way for help seeking around the clock for less educated, more disadvantaged and isolated people, and that they are used to seek and share support, to share and find information, and to memorialize the loved one, also for meaning making. So very useful tools with some negative effects, but very rare. And so the evidence are scarce, but showed encouraging results. Then we went to the second step of the study by doing an online survey for people burdened by suicide. We also published the result in Psychiatry. 401 participants, mostly women, mostly parents bereaved by the death by suicide of a child. Half were bereaved for more than 3 years, and the other half less than 3 years. So we had a lot of people participating, and what was really interesting was how they used existing online resources, mostly social media, and what they expected about new online resources, resource for people burdened by suicide. We found that they mostly used and expected to find information on suicide and suicide bereavement. There is a great need of information due to the lot of questions that suicide bereavement carries. And so that was a major point for us in terms of designing the platform. We also found that accessing peer support, especially finding some testimonies of other people bereaved by suicide, or being able to meet online other people bereaved by suicide, was really important in terms both of use and expectations. Memorials were also used and expected, despite the evidence were quite were not in the line of helping us in developing a memorial, online memorial, because they showed in the literature that they can have some negative effects on the bereaved. Interestingly, seeking counseling was not a way of using online resources for people bereaved by suicide, but there were a huge expectation about that. So we needed to be able to meet this need of people bereaved by suicide. Then we did some focus group with people bereaved by suicide, with people from charities dedicated to grief and bereavement, and with healthcare professionals specialized in postvention. And they offered us like a roadmap of what should an online resource for people bereaved by suicide be and do. First, it should offer validated and relevant information on suicide and suicide prevention, and also bereavement, provide guidance to people bereaved by suicide. Third, be personalized and anonymous, centralize existing and validated knowledge on suicide, postvention, and bereavement, but also centralize existing resources for people bereaved by suicide in France. So at the end of the first step of the study was like a brief design, which means that the startup was able to build a first pilot of the platform, and then through many workshops, 6 in total, with 31 participants, again, people bereaved by suicide, people from charities, members of charities, and healthcare professionals. We had several workshops to work on the platform to improve the design, the content, the functionalities, and to have like a kind of final pilot of the online resource Espoir. And then after these first steps of relevance, then of design, we had the last step, the rigor cycle, which aimed to ensure that our final platform was really efficient, easily usable. So we did some user tests and semi-directive interviews with 30 people bereaved by suicide to know how, when testing the platform, they felt and what they thought about the platform. So 30 people bereaved participated in the cycle, 26 women, 20 bereaved by the suicide of their child, I mean age of 53 years. And what we showed is that by using the system usability scale, which is scale from 0 to 100, and when you're above 80, it means that the usability is good, and when you're above 90, then it's really good usability of the resource. So as you can see, our score was 20.3, sorry, and 93% of the participants rated the system usability scale score above 80. So that means that we were able to meet the needs of people buried by suicide with a very usable platform. They also, in the interviews, shared some perceived strengths of the platform, notably the aesthetic of the website. They found it really calm, sweet. The main functions of the platform, I will say what are the functions then in the next slides, and the ability to access to testimonies of people buried by suicide, so which is quite in line with what I presented earlier. But they also write some possible improvements. For example, many of them were not able to access back to the home page, were facing difficulties to see their favorite options or to reach the national lifeline for suicide prevention. They said that we had to simplify the names of the subtopics that were maybe too designed for people with knowledge on postvention and suicide burial. So after all these months of work and research, we launched Espoir on March 2023 with 4 main functionalities. The first one is the ability to ask a question to our team. So the Espoir team includes psychologists, psychiatrists, nurses, but also peer workers. So the questions that you saw in the first slides are questions that came to us, and we do not answer directly, but after 2 to 3 days, we take the time with all the team to provide the best answer for the people. They can also find information through articles, videos, podcasts on suicide, on suicide bereavement and postvention, as mentioned earlier. Another functionality is to find support nearby through a dynamic map of France. Wherever you are in France, the map will help you to find a charity, an hospital, a counselor that will be specialized in grief, bereavement, or in suicide prevention, and that will be able that you can reach to find support. And as I said, you can find some testimonials. Some of them are audio testimonials. Some of them can be read. And you can submit your own testimonial. So we have a lot of testimonies, always more testimonies on the platform. I think I will have to finish soon. So since the beginning of the launching of the platform, 32,000 visits were recorded. 140 resources in France are now can be found on the platform, and we received approximately 140 questions on the chat. So a great need for people buried by suicide. Maybe I will finish by showing that there are some peaks of use of the platform, depending, as you can see, on the moment of the year and the moment of awareness about suicide prevention and mental health. For example, on September, due to the International Day, but also in November, because of the International Day for people buried by suicide. As you can see, a lot of resources are now available in France and are can be found on the platform. To finish, sorry, that's not. I just would like to thank all my team, great people, especially Pauline Lotaille and Kouchim Bislimi, who did a great job and are still doing a great job on the platform. And if you're interested in knowing more about the development of Espoir, you can find our articles online. Thank you so much, and really sorry about the technical issues.
Thank you so much, Edouard. This is really extremely interesting, and I think it's so fascinating to see that you really had a research-informed process for the implementation, because what we typically have and what many of our colleagues also in Europe with regard to the programs and national strategies tell us is that you have either the research component and then it won't end up in a prevention platform, or you can do the prevention part without the research component. So actually, how did you manage to get this done in a research, in that research-oriented way? Do you have any specific funding in France to get this type of research and prevention funded, or how did you do it?
Yes, sorry, I talked about the founding, but maybe it's when the didn't work. So we were founded by the National Institute for Research in Public Health. So we had a funding for 2 years of research in 2021. The founding allowed us to found what we call a research project manager, who was Kushim and then Pauline, and so was able to manage all the process of the research and ensure that we are going through the steps of the study, because as you saw, it's a lot of steps, the survey, the systematic review, then the focus group. So that was quite a job. But thanks to the foundings and the project manager, we were able to keep our mind focused on doing research, in the same time research and implementing the resource.
Great. And another question now, in many countries, we have assisted suicide either already for quite a long time or just really very new problem or issue or topic in suicide prevention. Now, when it comes to your platform, I think France has also legalized assisted suicide a few months ago. So are you considering having some specific component for suicide bereavement when it comes to assisted suicide, or any thoughts on that?
Yeah, thank you. That's quite complicated question for the moment in France. There are some, that we are facing a lot of political problems in France. So the legalization for the moment of assisted suicide is, I would say, freezed, but I don't know how it will go in the next months. But that's quite a question. For the moment, the specialists of suicide prevention in France are ready to tackle the issues of assisted suicide. But for the moment on the platform, there is no special part talking about assisted suicide. But if it's legalized in France, of course, we'll see that. And another point I didn't mention is that the platform is designed mostly for adults. And so there's a big issue about kids, children and adolescents. So we just received a new funding to implement part of the platform for children and adolescents, so the Espoir kids. So there's another research process to find the best way to reach children and adolescents and to answer to their specific needs when it comes about suicide bereavement.
Great, thanks. Now I'm looking at the chat. I don't see any immediate comments. There's someone, one of our participants posting a platform for the Netherlands and from Belgium, Flanders, also Postvention platforms. And there is one question: who answers the questions and how quickly do people get a response and how do they receive their answers?
So thank you so much. To answer the questions, we have a pluri-professional team, including psychologists, psychiatrists, nurses, and peer workers, themselves being buried by suicide. And so we do not respond immediately after the questions, to take the time to really together as a team provide the best answer. But generally in 2 to 3 days, we try to answer. And for some really complicated questions, sometimes we have complicated questions, it can be 1 week, but then we will write to the people who ask the question to say, we are very sorry, we need to reflect as a team before give you the best answer, so we'll answer in a few days. But generally in the week, and I would say in the 2 or 3 days, we answer to questions.
So there are no more questions. So thank you again, Edouard, for sharing your insights.
Thank you so
Thanks
much
to all of our speakers for their for sharing their insights and also for coping with the distress with the technical part. Thanks also to the Central Admin Office and specifically also to you, all of the participants who stayed on in spite of our difficulties. So we certainly try to solve this for the next time. And the next webinar will be in a few months. The Central Admin Office will share the specific link. Thank you again, and the recording will be available online. Thanks and good afternoon.